facing these challenges, and we want together to get out of these challenges. And hopefully you get something out of this webinar. I'll throw some questions to you throughout the webinar. Please give us some idea about this. But anyway, it's my pleasure to invite Dr. Hamad Al-Jahdari, who's an assistant professor of medicine from Abdulaziz University, a well-known consultant gastroenterologist and a therapeutic endoscopist, an advanced therapeutic endoscopist in Jeddah. He will talk to us about what should we know about endoscopy practice during COVID-19 outbreak and how to handle these risks and manage them. So I'll silence myself because I'm the reason for the input, and Dr. Imad will be better talking for you now. From now.
Thank you so much, Dr. Faisal, for inviting me to present this lecture and this great teleconference. One of the advantages of coronavirus that had empowered and give us an advantage of utilizing our time when we're away from the endoscopy units. So the biggest challenge, as Dr. Faisal mentioned, that our greatest deal, that how can we deal with the risk of contaminating or self-infecting our staff in endoscopy with COVID-19. So I'm going to focus on my presentation briefly on the definitions and common facts about the COVID-19 and how can we basically determine how contagious is this virus and how can we actually prepare our unit, endoscopy unit, and our staff as well as ourselves to deal and handle those patients, whether they are suspected or confirmedly positive, safely without causing more disasters. As we all know globally, more and more healthcare workers are actually getting infected and sick by this virus, indicating there is a critical situation about understanding understanding how to deal with this virus. So starting with a very basic introduction, trying to familiarize ourselves with the coronavirus. Basically, they are non-segmented, enveloped, positive single-stranded RNA viruses. There are 6 coronavirus species that are known to cause human disease. Most of them are generally mild, do not cause serious health problems. However, we have over the decade identified 2 serious ones. The first one was severe acute respiratory syndrome known as SARS-CoV, that was in 2002 pandemic, and the Middle East respiratory syndrome coronavirus, which is also known as MERS-CoV, that was in 2012. In December 2019, the World Health Organization China office was informed of cases of 2 pneumonia that were unknown in the city of Wuhan. New coronavirus have emerged and joined the coronavirus family known as SARS-CoV-2 that was extracted from the lower respiratory tract samples of several patients infected in that part of the world. In March 11th, 2020, the WHO has declared the infection as pandemic, affecting so many countries all over the world on the surface of the globe. And since then, as of April 2nd, 2020, more than 900,000 cases. As a matter of fact, today we reach beyond or above 1 million infected. The United States, as far as now, has the #1 rank in recording cases as more than 200,000 confirmed infections were reported and over 5,000 mortalities have been reported. Now, what about the clinical features of the disease? The most common symptoms, of course, which we look for most of the time are fever, weakness, cough, and diarrhea. Peking University First Hospital in China reviewed retrospectively the GI manifestations and fecal test results of COVID-19 patients. Most of them have reported actually GI manifestations, including anorexia being the most common, diarrhea affecting both children and adults with a mean duration of 4 ± 2 days, observed before the onset of upper respiratory tract infection symptoms. Vomiting ranked 3rd, and it's more prominent in children, followed by nausea, abdominal pain, and the least common in terms of GI manifestation is bleeding. Adult and children can present with digestive symptoms before or in the absence of respiratory tract symptoms. The proportion of GI symptoms correlate with the severity of the case. That means the more severe or sicker patient, you will likely have GI manifestations. How does it transmit? Now, human-to-human transmission occurs primarily through the direct contact or air droplets. Now, the higher risk of transmission is within approximately 1 meter or 2 meters away from the infected person. Although healthcare personnel working in endoscopy unit are considered less exposed to these patients, but the more data unfolding every day and every week actually have reported us wrong, as being more than 40% of all SARS-CoV-2 infection may actually be transmitted prior to the index case, which is the origin of the infection, has declared any symptoms. That means all patients undergoing GI endoscopy in an area of community spread need to be considered high risk, as more likely the patient or the individual that you're performing a scope on is actually infected. Now, endoscopy procedure demand short physical distance. As being an endoscopist, I have to be in a very close vicinity to the patient, and that indicate a high risk of transmission. All endoscopic procedures considered aerosol generating procedure owing to the possibility of coughing, retching, and passage of flatus or stool during the procedure itself, which both can be transmitting the infection. As a matter of fact, looking at the fecal transmission, risk of fecal transmission for the COVID-19, ACE2 receptor and virus nucleic acid protein has been detected in GI epithelial cells, and infectious virus particles were isolated from feces. Now, fecal PCR testing was actually accurate, or as accurate as the respiratory specimen PCR detection. About 50% of fecal PCR become positive in a matter of 5 days after the PCR of the sputum itself. Fecal excretion can persist after the sputum by 11 days. That means after the PCR turns negative in the sputum, you can still shed some virus in feces. Risk of infecting endoscopy personnel is not limited to upper endoscopy, as we mentioned, and confirmed that the virus can be shed in the feces, considering the recent detection of the COVID-19 in biopsy specimen and stools, suggesting, if not confirming, fecal oral transmission. Now, how do we practice endoscopy in this outbreak? Now, the median estimated incubation period of the virus ranges about 5.5 days, with a range of 0 to 14 days. 80% of patients actually are asymptomatic or having mild disease, specifically for those are younger than 60 years. Data clearly show that a significant number of patients undergoing endoscopy procedure may fall in that group, means they are asymptomatic carriers. Therefore, preventive measures are mandated and necessary. Now, when the patient reaches the hospital, a nurse-directed triage, which most of the hospitals right now are conducting for safety, should be applied to stratify the risk of COVID-19 infection using the following question, asking the patient directly if over the past 14 days they had any fever, cough, or sore throat, or even respiratory problems. Have they had any family member or close contact with a suspected or confirmed case of COVID-19? Have they visited any areas of high risk? Now, also checking patients' temperature while they are getting into the endoscopy room actually may re-stratify the patient if fever was detected. Actually, those patients are high likely to be carriers or even infected. Caregivers and relatives of patients should not be allowed to enter the endoscopy room, as that may increase the risk of transmitting the virus. Now, this is the table taken from Dr. Rapich's recently published articles, stratifying the patient based on answering the questions between low risk all the way up to high risk. High risk if they had any, at least one symptom of upper respiratory tract with one of the following, such as contact with COVID patient or staying at high risk area during the previous 14 days. None of these questions answered, that means no risk or low risk. Now, while after you triage the patient while they're entering the endoscopy unit, if the patient is moderate risk or high risk, or even non-risk, all of the patients getting into the endoscopy should be wearing surgical masks. Now, if they were classified as intermediate or high risk, then on top of the surgical mask, they must wear gloves to decrease or minimize the risk of spreading the infection on the surfaces. The surgical mask has to be on the patient, only removed just before commencing the procedure. Now, how about the endoscopy staff themselves? They have to keep a reasonable distance from the patient, somewhere between 1 to 2 meters, which is social distancing, as proven to be the most effective way in eliminating the risk of transmission. They have to wash hands using the soap or with water or alcohol-based hand rub before getting into the patient, after leaving the room, before putting the gear, or after removing it, and including gloves as well. We strongly discourage the use of any disposable devices after using them in a procedure, because that may increase the risk of transmitting the infection. Now, one thing I would like to point at, all endoscopic procedures are at risk of generating aerosol and microdroplets by the very design, function, and leakage of the instruments. As we know, the area of the valves as well as the biopsy channel, they can actually, under the pressure and insufflation while suctioning, they can eject some micro droplets that can linger in the air for a while. That's why we consider these particles not just droplets, they are micro droplets, meaning they can travel for a longer distance and they can lag in the air for a longer time. That's why we should take that in consideration while practicing endoscopy in this time, and all time maybe. Now, this is a slide comparing how we can stratify and take preparations for patients when they are stratifying them to low risk, intermediate risk, or high risk. For low risk patient, you can be happy or okay with wearing surgical masks. You should always wear a hair cover, as well as goggles and single-use gown. Now, intermediate risk and high risk, you should bring the measures to a higher extremes, meaning that you should be wearing N95 as well as a long gown to protect yourself, double the gloving, and shoe covers. Now, we're going to touch on this at the end of this presentation, as different hospitals may practice different PPE based on their resources availability. But what is actually preferred and what is acceptable? The preferred one is you must have a hair cover or head cover, a face shield, PPE, an N95 mask, or anything equivalent that is considered highly filtrating, any 300 micro size particles or higher, a long gown that will protect you from any splash or droplets, double gloving, as well as shoe cover. Now, if you don't have the N95, you can still be wearing the surgical mask, but you must have a face shield on and the rest of the PPE gear, which is personal protective equipment. Now, in putting on the gear and removing it, you must master and practice those steps, because you can still transmit the infection if you did not follow the proper stepwise approach. Now, first of all, you should cover your head, wash your hand, put the gown, then wear the mask, whether it's N95 or surgical mask, put the face shield, if your mask is not actually involving one, then put the goggles, double gloving. Now, after you're done with the procedure, while taking them off, wash the gloves again, remove the gloves, wash it second time, and put another set of gloves while you're removing the rest of the gear in a stepwise fashion. At the end, you must wash your hand after you remove the gloves. Now, in my practice, what I do actually, I put the double gloving, but I use the first glove to basically take them off, and the second glove to take the rest of the gear, considering that pair of gloves actually clean. If you don't have any break on the glove or anything that would indicate the glove is damaged and the risk of contamination is there, I would still use these as we are recommended to save resources. Now, what about negative pressure room? Now, as most of the societies, especially the American one, recommend performing all endoscopic procedures in a negative pressure room, it is even much more restricted and necessitating doing that when you have a COVID or suspected patient with COVID. That's the recommendation. Now, in facilities where you don't have negative pressure, it is recommended that you perform the procedure in any space in the hospital where negative pressure is provided, granted that that place has the equipment that you need to conduct a safe and proper procedure. How about reprocessing the scope, the flexible scope, and the reusable accessories? Should be processed based on the guidelines as uniform, standardized reprocessing procedure. You must use disinfectants that are bactericidal, mycobactericidal, fungicidal, and varicidal, including enveloped and non-enveloped viruses. Now, we have reported actually some viruses which are considered stronger and much more stable than COVID-19, such as hepatitis B and hepatitis C, as positive after processing these scopes. But the reports have indicated that the proper approach was not followed. That means the cleaning was not inappropriate. So we highly recommend that we follow and stick to the guidelines. Now, how about decontaminating the room after the end of the procedure? Now, cleaning all surfaces, consider them are contaminated, including furniture and anything that would have soil or biofilm. Clean all. Data on the virucidal efficacy of chemical agents against COVID-19 is not available, but we are using, based on our current recommendations, are based on what we had before on the other coronaviruses, which proven to be effective. Now, COVID-19 is known to be stable on the in feces and urine, at least for 1 to 2 days. Therefore, surfaces must be possible source of contamination and had to be cleaned clearly. And all these remains have to be cleaned very well. Endoscopy furniture, we mentioned that they should be thoroughly disinfected at the end of each procedure. In a negative pressure room, a delay of 30 minutes should be applied to allow the cleaning and removal of all droplets from the room. But in case if you don't have a negative pressure room and you're forced to do an emergent procedure, venting the room by opening the doors, letting ventilation recirculate the air for at least 1 hour could be effective. Now, me in our last procedure done at the King Abdulaziz University wearing the PPE, including the head cover, the face shield, the N95 mask, which I wear in all patients, whether they are high risk, moderate risk, or even low risk, because we're still learning about this virus and procedures are considered still high risk and there's possibility of having micro droplets. That's why I recommend myself wearing the N95. I'm wearing a long gown, double gloved, there is a glass shield you cannot see in the back between me and the patient. The scope channel is pointed away from the remaining staff, meaning the biopsy channel, the knobs, as well as the valves are pointing far away from them, so they are not at risk of being exposed. The shoe covers are as well. Now, to conclude this presentation, COVID-19 can be transmitted by direct contact, droplets, and feces. Some reports indicating possible airborne transmission, especially when dealing with procedures such as endoscopy and in very close premises as we are doing in our scopes. All elective non-urgent procedures should be postponed until after the COVID-19 surge is over. Suspected or confirmed patients should be wearing surgical masks to minimize the risk of infection. Endoscopy procedures for suspected confirmed patients should be performed in a negative pressure room, and staffing of endoscopy rooms should be reduced in number to minimize the exposure of the team. And they should be wearing actually the PPE that should be utilized response as we have difficult sometimes with resources. All members should follow the recommended guidelines about wearing and taking off the PPE as indicated here. That's the end of my presentation. Thank you.
Right. Thank you very much, Dr. Imad. We'll probably keep the questions to the end of the session for question and answers. And we'll switch gear now to Dr. Majid to present us about leadership in crisis. Dr. Majid, are you on with us?
Yeah, hi, I'm with you, but I'm getting like 2 minutes to upload the presentation, so it's going to take like a minute or two.
So I'll probably, for the audience, I'll send this poll to you. Please give us an idea and give us a response about this poll, because we want to know if we would do this again in Ramadan or not. Would this activity will be useful for you or not? So we'll wait for your response. Meanwhile, Dr. Majid prepares the presentation. Dr. Imad, thank you very much for the presentation. That was a wonderful overview of endoscopic precautions during endoscopy. Majid, when you're ready, let me know, please. Okay. So I'll probably pose the question to you, Imad, if you can reply to that. So we got a question from the fellows in training about their training, and they concerned that's a precaution that they would take during this presentation. So I'll probably read the question to you in a minute. I need to go into my website or the Twitter account to that. So what do you recommend for the fellows for now, Imad? So their question was, your mic is off, Imad, so you need to open the mic. Okay. So their question was, any advice for GI fellows regarding maintaining, improving our endoscopy skills during the time of COVID-19, given the time lost and not doing regular endoscopies? I still don't hear you, Imad Tara. Imad, your mic is off. You turn off the mic, turn on the mic from above the screen, please. I don't hear you, Imad. Majid, you're on?
I can hear you, but I still have this thing, it's still loading.
طيب عماد أنا ماني سامعه. I don't know what's happening to عماد. عماد. Okay. طيب I think we lost عماد. دكتورة نهلة أنت معانا؟
ايوه
انت تجاوب على السؤال قبل ما يجي اظن عماد خرج من الغرفه فارجع لها ثاني.
السؤال about the question about the fellows.
How the fellows have to handle the crisis now, because they're having difficulty with their training.
Nobody knows actually about this question so far. Even I attend some.
Okay. Yeah. And I'll ask Nahla to talk to Omar. Welcome back, Omar. So Nahla, so you think there is no? So the question is about the fellows, Omar. They're asking.
So basically, I got the question. So it's actually a major problem. But I'm actually one of the program directors at our local institute and running a GI fellowship. We consider safety first. I understand the frustration of the fellows that basically not doing enough procedures, but in these exceptional circumstances, we're dealing with such a pandemic where health workers are actually are falling as victims, and that's with no exceptions, whether they are fellows, consultants, or not. We consider the safety of our trainee as a priority. and the safety of our staff as a priority. That's why we're decreasing the flow in terms of patients. We're trying to minimize the exposure, separating them in on calls, and be sure that we hold our stronghold strong. Other things that we, instead of maybe engaging them in procedures that could be very risky, they can learn a lot from handling this pandemic and dealing with this stressful situation. How can they manage reorganizing their patients and prioritizing their need? That's all is considered as part of the learning curve, which is exceptional and never. I myself, when I was trained overseas, I never had this experience. It's all new to us, but we are learning a lot. So what I would recommend, number one, is safety comes before training in these times. Number two is it's a good time to learn how to handle this similar pandemics maybe to follow in the future. Number three, we have to put patient safety as well by decreasing the flow, staff working with us, including the nurses. And in case if you're questioning if the time comes and the fellow wasn't exposed to enough procedures to train them well, I think in those cases we should extend the training time so they can learn more.
You ready?
I'm good. If you want to start, we're good.
So I'll probably ask you all to keep the questions and keep posting your questions. We'll try to answer it all in the question and answers session. And I'm waiting your full contribution. Please share your thoughts. We'll go with Dr. Majid. Dr. Majid is the SGA president, a well-known figure in Saudi Arabia. He's an associate professor of medicine and consultant gastroenterologist, as well as an advanced endoscopist, as well as he's an MBA, executive MBA candidate. So in a few months, we'll all probably graduate. So I thought of when we designed this project to know how to handle crisis in leadership, or leadership throughout crisis. How do we manage this? So Dr. Majid will give us an idea. How can we handle this? Dr. Majid, the floor is yours.
Okay. Bismillah ar-Rahman ar-Rahim. So I'm going to give a brief talk about leadership in crisis, and small disclosure, you might hear kids screaming, knocking at the door, somebody getting kicked in the stomach. It's a normal process where I work. So just to iterate on the issue of this being a crisis, this is a true crisis in every meaning of the word. People's livelihoods have been affected, people have died, economies have crashed, people have been laid off work. So it's a real crisis in any aspect. And then we're going to use a few examples from around the world just to iterate on the concepts of what should be done and what might be best done in a better way. So this is a picture from South Korea, and you can see people wearing their protective equipment as if it were like a nuclear reactor accident. You would laugh at this a few months ago, but this is the norm now in a lot of cities that have been hit by the COVID-19 pandemic. This is another picture of New York, and the normal now you can see is wearing gloves, masks, and shops being closed and people running around getting their groceries just to stay alive. So you've seen the images of the grocery stores and the supermarkets with the empty shelves. So it has changed even people's behavior. It's changed how people communicate, how people commute, access to services, and people not even talking to each other, just showing each other signs, and then really have to prove where you're going, why you're going, and what you're going to do. So it has affected air travel, and borders have been closed. Also, what was exposed with the COVID-19 crisis and pandemic is a lot of healthcare systems that have pride in their breadth, their strength, and resilience have been put under a lot of stress. And it's interesting to see how people have managed this crisis in different manners in different settings. This has been a crisis even between science and politics. You can see Dr. Anthony Fauci's laser eyes looking at the President of the United States, and there has been a lot of stress between science and politics lately. And this is a picture of the governor of New York when he was giving one of his televised news briefings. And you can see he's stacked like personal protective equipment and N95 masks in the background as if they were gold. And he's protecting him with his life. This pandemic has shown how friable our supply chain is. And as physicians, it's not only enough to know how to manage your patient, you really have to think about where you're getting your stuff and who's purchasing it for you and are you safe or not. It's been even a stressful period for people that even public health officials and scientists don't have their act together. So this was a paper that came out the other day from Harvard, and an economist and an epidemiologist was saying, well, you know, this social distancing thing might not work because we don't have a vaccine in the near future and we're not getting herd immunity. So let's loosen up social distancing, get a few people infected, then put social distancing back again. And then when everything cools down, loosen a bit and get people infected again. So even like public health officials really don't know what's going on. And the models you've seen thrown around the internet all over the place, and it's been a disaster. So we're going to talk about a few leadership tips that you can use in your own small practice, in your institution, or depending on your influence and your position, maybe even on a countrywide or citywide policy. So as leaders, and you are all leaders in some aspect or capacity, you're asked to be a energizer, a catalyst, to grow your people, to grow your institute, to take care of your trainees, take care of your clientele, your patients, and all of that is like can be challenging and at some point might be even inhuman as what is required from you. But let's look at this issue as a problem. This is a big problem, but all of life is a series of problems, and you really have to work through them. So you've been through problems before, and this is just a different magnitude of a problem. And as curious as it may seem, people have looked at something like this, and there's literature on it. It's called mega crisis, transboundary crisis, or super wicked problems. And people have planned how you should tackle these issues. And then we'll just look at the small graph. If you look on the lower axis and looking at a person's goal or an institute's goal or a government's goal, is it clear to you or is it ambiguous? And on the left axis is your future. Do you have a stable future that can be predicted, or is it really unpredictable? So if you're in the left lower quadrant and you have a clear goal and you have a clear future, everything is steady, you know your patient flow, you know your clientele, your catchment area, your monthly volumes, and something pops up, it's called a problem, and you can solve that. But let's say the future is clear, everything's going well, but your goal of your institute or your division or your country isn't clear, then that's a mess, and there are ways to deal with that. Now, if your goals are clear, but your future is undetermined and it's very unclear to you, which is the current situation, our goal is to keep our patients safe, to give them the care they need, to protect our people, healthcare providers, resources, try to save the economy as much as you can, but the future is very unclear. It's called the wicked problem, and that's the left upper quadrant. The right upper quadrant is when everything's in a mess, and it's called the wild mess. One certain issue is when you make decisions as a leader, you should seek credible information, and your resources should be very clear, obvious, credible, and you can follow on them anytime. And I'll have to say, although sometimes WHO and CDC and the FDA don't have clear recommendations on everything, but it is a time of discourse. But at least try to seek credible information and build your decisions on them. And we're going to use government responses as examples of leadership. And I'll have to say upfront that the response of the leadership in Saudi Arabia has been phenomenal. And we're going to see that in examples that follow. One aspect in leadership crisis is to have the appropriate communication channels. You really have to communicate with your people, your healthcare providers, your managers, and your clientele, your people, your population. And the Ministry of Health in Saudi Arabia does have a hotline for people who can ask questions whenever they want. At the same time, they do have briefings on a daily basis that are at a predictable time with a predictable format and is consistent and simple and has a simple message every day and very transparent. That is of utmost importance in managing a crisis. The same thing is utilizing resources. So the Minister of Health tapped into different people with different credibility, trying to tap into the egos and trusts of different segments of the population. So using people and influencers to get your message through is very important. And I'll have to say that the MOH has done a phenomenal job in that aspect. Also, you really have to show your face. Be present, be there for your people. As leadership, you have to show yourself, be sincere in what you say. And the Minister of Health did give a televised statement recently. And you can see from the video, you have more than 11 million views. That's a huge audience to reach out to. And at the same time, they utilize multiple aspects. They utilize sign language, they utilize English translations at the bottom of the screen. All of those are excellent ways to communicate with the people what you want to do. And you have to tell them what you're planning to do in this crisis. Shying away in a room, closing on yourself in a closet won't make the problem go away, it only makes it worse. So all of this can be implemented even on your aspect as a program director, as a division manager, as a department head, as a CEO in a hospital. These concepts can be easily taken into account. Also, one aspect of leadership crisis is being consistent, and having a consistent message, simple, repeat it, and be very clear with it. That's the only way that people are going to listen to you and abide by what you recommend. And you can see in the MOH, they have a slogan that they've been using, Kulluna Mas'ool. They've been using it for a while, so all of us are responsible. And if you look at the slogan, which is very interesting, on the Ministry of Health website, they launched this initiative in 2017. And then they rebranded it in this crisis, which is very creative and building on a platform that's already available and being resourceful in how you manage a crisis. So this was there very, very long ago, and they repurposed it in this crisis. Let's compare that to the US healthcare setting. So in the US government has been criticized by giving mixed messages. If you look at the beginning of the crisis, the message that was told to the public were okay, it's not coming. It's nothing, it's just the flu. Then the message changed, well, it's coming and we're ready for it. Then a little while later, it became, it's coming and brace yourself for it. And now people are getting even mixed messages. We're not ready, we have the supplies, we don't have the supplies. That's not good to have in a crisis, which takes us to the second aspect of leadership, which is transparency. You really have to be transparent with your people if you want trust. This lack of transparency has been seen in multiple governments and healthcare settings in the UK and the US, even in Canada. There have been complaints about undisclosed intents and plans. And when transparency is not there, trust gets lost. There's a whole sequence on Harvard Business Review on leadership in the age of transparency, which I would advise people to have a look at. Another aspect in leadership crisis, leadership in the time of crisis, is creating a sense of urgency. You really have to rally people around you to solve a problem and to work on it immediately. If there's no sense of urgency, everybody's going to slack back, and you're going to see that in the concepts that what happened in the US. In the USA, this is Dr. Fauci briefing the Senate on March 11th, trying to create a sense of urgency very, very late in the pandemic. And you really have to be empathetic in your message. You have to be very sensitive to the people you're addressing. You can see that Boris Johnson's message to the public wasn't received very well when he said that we are going to lose loved ones and people that you care for. Although the message is true, although whatever you do, you are going to lose loved ones, but using appropriate body language, voice tone, eye contact, doing it in a sympathetic way that shows empathy and care for your people makes the world of a difference than we do it in a dry, scientific manner that shows that you're cold-hearted and you really don't care. Although it's the same message, the way you show it and you express it to your people is very important. Concept in leadership in general, and even in crisis leadership, is self-awareness. You really have to know yourself, your weaknesses, your strengths, what you're good at, and where you have to borrow from your people. And that only happens when you have 360 evaluations and people that show you where your deficiencies are. You have to have a clear mission, clear vision, know what you're good at and what you're not good at, and then try to build on that. And not to get involved into your self-awareness and become self-absorbed and lose sight of what's happening around you. When you know your organization and within where you're at, you really have to also have situational awareness, which is very important. And we see that a lot of countries fell into that trap. That's a cognitive bias. What you focus on yourself and your inner self, you don't know what's happening around you. So common phrases that you see when people have breakdown in situational awareness is, well, we thought that. We didn't expect that this was going to happen. We were busy trying to. All of these are statements that tell you that there was lack of situational awareness. You can see the US president in February 28th, he was rallying a campaign. Although at that time, you can see the lower arrow at that time point, there was an epidemic in China that already peaked and was coming down, and people were talking about it going around the globe. And you can see that by the time it was like mid-March, the arrow on the right shows you the cases that soared in the USA. Let's take that in context with the Saudi response. We'll just walk through the timeline. So on February 24th, Saudi Arabia got its first case that was diagnosed in Kuwait, and there was an arrangement between the two governments how to manage that case. 1 day later, Saudi Arabia advises against travel to Japan and Italy, which were two hotspots at the time. 2 days later, Umrah to Mecca and tourism were stopped from hot areas, and tourist visas were suspended the same day, those that were based on arrival, and that was a very fast, swift action. And then GCC nationals were barred from entering to Mecca to try to control this epidemic, when it was an epidemic then. This all happened before the first case was registered in Saudi Arabia on March 3rd. So that tells you that people were preemptively looking around them and devising actions even before the first case, which speaks to the swift response that was happening in the country. On March 8th, schools were suspended and land borders were blocked, apart from equipment and food and commercial trucks. And on March 14th, a stimulus package was given to companies because they saw that there was going to be stress on the economy and it's going to take a while. So again, this is situational awareness of what's happening around the globe, and this is going to take a while. So people took into consideration the financial constraints of people. Work in public places were stopped on March 16th. 17th mosques, prayers were stopped, and the curfew was started on the 23rd of March. And this is still playing out day by day. And you can see that this is all reflects situational awareness, that you have to really move fast. And Jack Welch, who's the CEO of General Electric, has a very nice quote that tells you that if you're not moving inside as fast as change is happening on the outside, that's your end. So situational awareness, some people use Cooper's colors. That tells you where you're at as a stage. When you're white, you really don't know what's happening around you, and you're not paying attention at all. When you're red, you're at heightened and responding to situations, which is not a good stage to be at. It's not nice to respond to catastrophes when they happen. You really want to be in your yellow area, which is actively paying attention to the surroundings and having plans ready. And at the same time, you're not going to have the information you need to make an excellent decision. You're going to have make a decision, whether you like it or not, even if you have uncertainty. And the Dutch Prime Minister has a nice quote: with 50% of being uncertain, you still have to make 100% of the decisions. So you will have to make decisions. If you wait for all the data points to come in your field and make a great decision, most probably it's already too late. Leadership styles differ, and although you can see that maybe in the military, the left upper quadrant where there's high alignment and low autonomy, it works in the military. And in startups, you'd like to be in the right lower quadrant where there's high autonomy, maybe low alignment to give people to work, but the best situation to be in is to be in the right upper quadrant when there's high autonomy and at the same time high alignment. So you tell people what you want to achieve, you don't tell them how you want to achieve it, and let them figure it out. Here you summon the strength of the masses and try to see what's happening. And the leadership styles do change. In times of crisis, you might shift from a delegating type of leadership style to a coordinating to have more control and faster actions. The same thing happens in a participatory type of leadership style that you might need to move to a more of a guiding style. And the other aspect in leadership in crisis is getting ready for future crises. It is going to happen again, whether we like it or not. And people saw this happening during the SARS outbreak. People saw it in the MERS outbreak. And I think Saudi Arabia did learn a lot from the MERS outbreak that we had. And that's why our responses are much firmer, quicker, and more definitive than other countries. And again, as a leader, you really have to walk the talk. It's the one who knows the way, goes the way, and shows the way. And we hope that this all becomes part of history and an experience that we don't live through again. So thank you very much. And I come to the conclusion of my talk.
Thank you, Majid. It's a really difficult economic talk, as Hoda mentioned in her comment. We'll move on to Dr. Nahla Aizam. Dr. Nahla, you're ready? Yep. Yeah, okay, great. So if you're ready to go over for the presentation, we'll leave the questions to the last and keep posting questions in the chat. We will follow on that soon, inshallah.
Okay.
So, Dr. Nahla, the floor.
Thank you, Dr. Faisal. Thank you for having me. As you all know that this is a public health crisis that all over the world with a lot of evolving literature and evidence on daily basis, which we are learning on daily basis. So I just give update about the latest update about IBD in the COVID era. The COVID, as you all know, is caused by family of coronavirus, which is never been reported in the human before. This is why it is novel, and there is no human immunity, no effective vaccine, no therapy so far, and the mortality is even higher than the flu vaccine. This is interesting website where they updated on live all the cases, a global case of COVID worldwide. We have so far more than 1 million cases with more than 60,000 people lost their life. It is spread through a droplet spreading through the droplet way, and once this particle of this virus enter the human body, it binds to what you call ACE2 receptor. This ACE2 receptor is expressed heavily in the upper airway and lung and blood vessel, and lead to the viral replication, downregulation of ACE2 and the subsequent injury in the lung and myocardial remodeling and etc. However, very important to know that this ACE2 receptor also expressed in the GIT tract. This is why among the GI among symptom in COVID-19 is the GI symptom. So as you all know about the GI, the symptom in general, which is upper airway symptom. However, report from China found that 1/5 of the patient in China reported some GI symptom in terms of diarrhea, loss of appetite, abdominal pain, nausea, and vomiting. And this is little bit will be confusing for us as IBD, treating patients with IBD, because our patients when flare, they present with such symptoms. So it would be confusing. This is related to the disease or to the infection. However, if you have symptom of upper airway disease with fever, you have to consider actually the infection of COVID. So it can precede even the respiratory symptom, and in some report associated with poor outcome. In USA, first time they isolated the virus in the stool in the USA because they used to swab everything from the patient. However, And not only this, it is has been found to also shedding in the stool for longer time than the respiratory symptoms. So it used to precede the symptom of respiratory, associated with poor outcome and poor prognosis, and can lag even behind the respiratory symptom. This is a latest article or evidence from reported in Nature in 2nd of February showed that the stool sample with live particle of RNA is still can be shedded up to like 6 weeks from the start of the infection. However, in this article, what they mentioned that whenever it's shedding, it's a live RNA particle. However, it's non-infectious. So the area of the fecal-oral transmission should be still considered, but however should be taken in caution. So back to our IBD patient. Are our patient with IBD more susceptible to SARS-CoV-2? There is initial reassuring data from the large 7-center referral center in China with more than 20,000 patients of IBD. They report no patient of IBD reported at that 7 center. And even in Wuhan, the beginning of the pandemic in Wuhan, 3 tertiary care centers, there was also no patient of IBD reported. Furthermore, if you look to the data from China about the case fatality, they found that the majority of patients who died are older age. So if you are actually the children initially do if age between 0 to 9 or even in adolescents, they do pretty well, and the one who really have high mortality is old age. So thank God that our patient is lying within the 2nd or 3rd decade. So this is one reassuring. The other poor prognostic factor from China CDC, apart from age, the patient who had a high health condition and comorbidity, which also our patient in IBD doesn't carry this comorbidity as well. However, China also reported that patients immunocompromised or in steroid are at a risk of a bad prognostic factor. I showed this slide earlier that about the ACE2 receptor, which is expressed in the gut and the lung, where the virus is enter and bind to that. Fortunately, the ACE2 receptor is 2 types: the full length type in the lung, and in the gut is the soluble type. And the data showed that the one in the soluble type of ACE2 receptor in IBD patient are less virulent than the one in the lung. Furthermore, as you all know, one of the life-threatening complication of the COVID-19 is what you call the cytokine storm, which is due to very super hyperactivity of T cell, leading to production of a lot of cytokine, include IL-6 and etc. And fortunately, our patients are suppressed or immunomodulator, which make block little bit the cytokine. So far it is reassuring, and even in some of the clinical trial going on using this IL-6 therapy in the treatment of the COVID-19. So among all of this, we don't have a case of IBD among those more than 1 million. And with this, the previous good news that I show you based on the evidence, after the spread of the disease from the China, outside the China, to the Asian country, European, then start to have some report about IBD cases. So this platform was created, which is Secure IBD database. I put the link. So anyone who had IBD case with COVID-19, they can enter the link and just register the case easily. This is to help us to understand and to know about this disease among our patients. So far, 275 patients have been reported. Crohn's was more than ulcerative colitis, male more than female. And if you look to the disease outcome based on the treatment class, I just took screenshot from this website. You will see the majority, this is reassuring that the majority are outpatient, they visit the outpatient and they didn't require hospitalization. However, even in patient who is only on 5 amino acids on mesalamine, they require, some of them require ICU and death. And by looking further to the cases of that who died, like I will show in the next slide, actually the age was contributing factor. Budesonide, almost zero fatality, which is the ritual. Steroids, 30% on oral parenteral steroid, as we are all expected. This is a very poor prognostic factor and can be a risk for this on our patient. Surprisingly, 6-mercaptopurine and azathioprine, they didn't do bad as we expect, because azathioprine suppresses immunity to the virus reaction. However, only 5% fatality. Anti-TNF, the monotherapy, only 3% hospitalized with ICU admission or death, which also support our understanding and previous study that biological mainly have a risk in bacterial rather than viral. However, if you combine both, it showed higher risk. Anti-integrin, Vido, ustekinumab are doing pretty well, and JAK inhibitor also. Only few patients reported. A majority was an outpatient, and also our concern about the viral or immune response to viral infection is still there and early to judge. Here is a disease outcome based on the severity. So even the patient on remission or mild, they still require ICU, and majority they were treated as patient. However, not only severe case, even mild and on remission, they could have high fatality. And by looking to the 12 cases that reported up to today, it is majority are this was among the old age group. So those old population of IBD are much higher risk. So this is from Canada. I don't know why more than 90 in remission. He was put on adalimumab. So a lot of things to learn from actually this database and from this pandemic. And the majority also very old age, and you can appreciate that also they hospitalized, but the majority didn't afford ICU or ventilation. That means they were triaging their patient because of the resource limitation. What treatment so far in COVID? A lot of trial in developing vaccine. There is the vaccine platform with different technology, different company. Also, it's not going to be released before the end of the year. However, just today, there's FDA approved about one drug which is well known to us, ivermectin, and it showed an in vitro good result. However, well-known recommendation and treatment that we are having is prevention by good hand hygiene, social distancing, and avoid travel to endemic area. By doing that, we can flatten the curve where this line where any healthcare can cope with this crisis. This is the healthcare capacity, trying to flatten the line so we can save more life. And actually our patient IBD, they require coming to the hospital frequently, and by preventing them from coming due to this crisis, it can have an impact. What have been done as initiation from different society to help our IBD patient? Actually, it has a lot of strategy initiated and initiative taken, like in China Crohn's Colitis Foundation. What they did initially in January 29, they did a virtual online consultation by volunteer gastroenterology from all over the country. They answer virtually or online the patient concern, which was I think has a lot of impact. Chinese IBD Society followed by that by a guideline on management of IBD during this crisis. ECHO, they released 4 expert interview. It's in terms of question and answer. They released the initial one on March 11. However, the 4th one was just yesterday. Crohn's colitis UK, they did what you statement plus some decision tree for the patient to stratify themselves, which I will talk in a minute about it. IBD, International Organization Study of IBD, they released a statement on from 76 points about COVID-19 and IBD treatment through the voting system RAND panel, and they updated a couple of days ago. Crohn's Colitis Canada, they also released a very nice algorithm and statement. HGA also had some initiative in terms of Arabic statement released on March 13 for all the patients. We put it on website, Twitter, to reassure them and to give them some advice. And we start serial webinar today. Most of this society and association, actually the key recommendation, they were almost having the same recommendation, that there is a certain group which is high risk, which is a patient who is active disease, elderly patient with IBD, patient IBD and pregnant, patient with comorbidity, and patient on parenteral nutrition. Those are at a high risk, and regarding it has to keep eye on them with a special recommendation. However, the medication, most of the society or association at this up to this moment, there is no evidence to pause or to recommend to pause or to stop any of the medication, because if we stop the medication, also it is immune suppressive medication. However, if we stop it, the risk of flare is higher, and they come to the hospital requiring steroid, which is much higher. This is Crohn's Colitis Canada. They put this very simple recommendation in very nice way. I found it interesting and nice to present for us to follow. I think so they categorize the patient profile into 3 risks, either low risk where IBD in remission or no activity, not malnourished, and not old, under 65 years old, or not on any biological or comorbidity, so they have only to follow the standard precaution, which is hand hygiene and social distance. Any patient who is on immunomodulator or biological apart from methylamine or budesonide, they are a medium risk, and here they ask them to avoid any meeting, and even if they can work from home, and to avoid contact with other people, and to go like once a week for grocery or whatever. Other patient, old or with comorbidity or any steroid or moderately active or patient or parenteral nutrition, they have to self-isolate themselves from their even other family member. IBD in latest update, there is 76 points, and I put the link so you can go over it, but they were certain and clear that steroid increase the risk, and we should try to taper it as much as we can. And they also put a point where it is all of us was questioning ourselves and our colleague what to do in newly diagnosed or active disease. So they put a statement that moderate to severe active disease should be treated in same therapy like you would choose in a pre-COVID-19 era. And some of the experts, they recommend, the worldwide IBD expert recommend a swab for COVID-19 before starting biological as a pre workup before the biological. The other recommendation, if the patient tested positive, swab positive, but not disease, no symptom, the medication should be stopped and not to restart before 14 days. However, if the patient develops symptom, then the medication also should stop immediately and not to be restarted unless symptom resolved and after 2 nasopharyngeal PCR tests negative consequent. Crohn's colitis UK, this is my almost last slide. They did what you propose, what you call decision tree. They involve the patient. Here is that they involve the patient to make some decision about their take action based on their risk. So they send a message to most of their patients and their database through online clinic or a virtual clinic, emails, and their website, and they ask them if they are do you have any of the following apply to you, which is the left upper quadrant. This is the high risk, which is the same high risk group. Then they ask if yes, then they ask them to shield themselves. Shielding means stay at home 12 weeks. Within the home, not to go out, not to contact even with a family member. It is a little bit strict one, but I think it is for high risk group wise to be that. If you, what I have mentioned is the strategy and initiative by different society, which is a different organization. How about the individual level? Also, people trying to share their experience, help each other, and understand more about the disease. There is a Twitter platform which most of us are following, Monday Night IBD, where different gastroenterology they share between us their experience. Even they put some proposal IBD algorithm, which is based on resources of CDC, ACG, WHO, IO, IBD, and etc. And very nice also to look at it. So this is by this slide I finish my presentation. However, I pray to God and to stay all healthy and wish Allah protect all of us. And you have to follow the recommendation of protection by PPE or person protection gear, as Dr. Ahmed mentioned. However, you have to be also clever in managing your resources, like Dr. Majid explained to us, so not to end with short of mask like this cartoon. And thank you.
Thank you very much, Dr. Nahla. Allah يعطيك العافية. So in the last call, and we'll go over the questions one by one. So do you hear us very well, Dr. Majid? Yeah.
Yes. Yes.
Okay. So we'll start from the first question that we had from Ghada Ismail. Any further details on South area associated with COVID-19?
What was the question? Sorry.
Any further details on the type of diarrhea that is COVID-19?
I really don't have any data on that, but I would assume like it's almost the same cause of any gastroenteritis, where actually there is an inflammation of the GI tract. Now, what kind of inflammation, how severe it is, I don't think anyone had the scope or have any information based on this. But the fact they found the virus within the epithelial lining of the GI tract indicate there is some sort of invasion or involvement of the epithelial GI tract. I don't think the virus is secreting any toxins. I cannot provide any information on this as I'm limited on the data. As I said, we're still learning about this virus and more to unfold as we study these patient more and more. But something to worry about, that the content of that stool can be contagious. So you have to be careful about that.
The next question then about the PPE.
Yeah.
What should we do for outpatient?
What should we do for
Outpatient clinic?
Oh, outpatient clinic. So, so there are too many different practices. Other hospitals, they have basically followed this protocol where all elective clinics have to be canceled. Actually, you're not protecting only your staff from getting infected, also you're protecting from patients and relatives coming to the hospital to contract any infection and go back. So the model we are running in our hospital is we basically conducted virtual clinic where we basically review the appointments and call the patient in advance and tell them, listen, I am calling you regarding your appointment. If you have any concerns I could address over the phone, then for your safety, I would recommend that you stay home. But if you feel that you need to be seen and examined, then I run them through the questionnaire. Do you have any fevers, any symptoms of upper respiratory tract infection, any recent travel, any exposure to COVID patient, making sure this patient is a low risk to have a COVID virus. And if that's all no, then they are more than welcome to come. And if we could address over the phone, that's beautiful. So outpatients should stay home. That's the best for them. Best service ever is to call them at home and see if they could address their problems over the phone. And otherwise, you can postpone or reschedule their appointments.
Thank you, Ahmad. So, the question for Dr. Nahla. Patient known to have UC admitted with suspected symptoms of flare, UC, and she needs to do a sigmoidoscopy and suspect infected COVID, where the results are still pending. What is the right way to manage the patient with the result, or start infected treatment to take some precautions?
I cannot hear the question. Again, Dr. Faisal.
I think he's trying to type the question.
Yeah. Dr. Nahla?
أيوة, now I can hear you.
عيد السؤال ثاني.
أيوة يا ريت.
Patient with an UC and has a suspected flare, and she needs to do a sigmoidoscopy and suspected COVID-19. The results are still pending. What is the right way to manage this patient?
Still, I cannot hear the question. However,
so I think it's also a UC patient presented with symptoms, UC flare, and you want to do a sigmoidoscopy, and you think this patient is infected with COVID.
Yes. So by criteria, if you look to your risk stratification, those patients are almost moderate risk, so they are immune compromised. So we'll follow the precaution of moderate to high risk with full PPE equipment, N95, and I will not delay because this here there is a decision on management and ruling out other infections like CMV, need a biopsy. So I will do endoscopy. It is urgent case. I will consider it of moderate risk with all precaution, and I will do endoscopy because the management will here. A decision of management will be based on that. And as I mentioned in my talk, that we have to treat it as pre-COVID era. So based on the severity, you go from
Christian Ahmad.
Yeah.
What criteria for elective procedures during COVID-19 or non-COVID-19, outpatient, inpatient, and so on?
So it's perhaps easier to answer the question as who should be scoped or who should be considered as an emergent and should be scoped. So all bleeding patients are considered, especially those coming to the ER, are considered as an emergency. All ERCP presenting with sepsis or biliary obstruction, or patients coming with food impaction, and sort of all emergencies that the patient cannot basically be sent home and be safe. That's an urgent procedure or emergent procedure. Now, the less urgent procedure and should be selective, meaning that you should book them for the endoscopy as an exceptional elective, is any cancer patient, anyone that need to confirm the existence of cancer so they can at least have tissue diagnosis or treat them, or those presenting with cancer complications such as esophageal obstruction, they need stenting, or colonic obstruction, they need stenting. So all of these patients are considered. Anything else can wait. Anything, whether it's let's say celiac disease patient to confirm testing, patient with GERD, patient with reflux, patient hiatal hernia, patient with unexplained diarrhea, maybe some sort of abdominal pain, screening scopes. All of these things are considered elective and should be rescheduled till the COVID-19 surge is over.
Okay. So I'll take the next question, and I apologize about the echo because my headphones all tell me. So, question: did the IBD consider the immunosuppressant?
Do IBD patients considered immune suppressed?
Yes, I think it should be considered. However, as I show you, there is reassuring data from China and from the secure IBD registry so far. However, they are immunocompressed, especially the one on steroid or parenteral steroid or active patient on active disease or on pregnant lady. So those group of patient, high risk patient, we need to keep them in mind in managing those patients and keep eye.
Another question. Would you switch from infliximab to Humira?
Okay, this is an important question. With the beginning of COVID-19 pandemic, there was some thought about shifting because of the infusion unit and the risk of coming to hospital, and there was some advice that let us move from IV to sub-cut injection. However, especially in patient who is complex or in control, you might lose the response, and losing the response is outweigh actually the risk of coming to the hospital. So some strategy in some of the country worldwide where they have what we call home infusion, they have dedicated IBD or nurse practitioners where they can go to the home. I think this is a good option for the home infusion. However, in a country where it is not available, this facility, so shifting to subcut, it might make your patient lose the response and can be led to flare and subsequent coming to hospital requiring a steroid, and this is much more higher risk currently, especially with the data so far in secure IBD registry and one on infliximab or biological so far, especially monotherapy is less risk, and the only thing that we might think of it is just to de-escalate the very patient who is in deep remission, who is in stable condition, where you can de-escalate with some reducing the immunomodulator to keep them on monotherapy of infliximab. However, it has also to be with caution, with extra caution, because if they flare, also the risk is much higher.
طيب, I think we probably we're gonna conclude this session. Thank you very much for attending with us. Some of the questions will be answered in the next webinar, like how to arrange your endoscopy lists, how to reshuffle your listing, because you know this COVID thing probably gonna last for a few weeks to months. So we need to handle our care of patients and our IBD patients. And I want you to draw your attention to the guidelines published by the Saudi Gastroenterology Association about the use of biologics in IBDs and how to manage IBD patients. And I hope next webinar will be much more fruitful to you. We would love to hear from your feedback, how to improve this. Dr. Georgios Zakarikis has pointed some useful points about that Europe are not screening anymore, and they don't qualify patients as high risk or low risk anymore. They treat everybody as high risk, and I encourage you also, when you practice, to encourage to manage every patient as high risk. And I hope we all pass this period of COVID, inshallah, safely. Thank you very much all for attending. Thank you all the speakers for being part of this project. We'll hope to see you again. And thank you to our sponsor, Pfizer. They have been very helpful and supportive to us. And the SGA is our home. Thank you very much.